uh, this webinar is being recorded and will be available for future reference and for people that couldn't make this time. So one final word is that I would like to thank, I would like to thank our partner Cepheid. They are a diagnostic company, but they have had no influence on the content of this, but they are great and they really want people who care about C. diff to understand how all of this works. So without further ado, I'm going to turn it over to Dr. Brecher, and I'll let you begin the presentation.
Good afternoon, I guess for most, and thank you, Christian and Peggy Lillis and Cepheid. Let me get to start sharing. Oh, wait a minute. Okay, so that first of all, I work at the VA, and what I'm going to be saying today is not the opinion or the views of the Veterans Affairs healthcare system. They're solely mine. So I'm not able to right now advance. Oh, here I go. So I've been working in some form or other in microbiology for now 50 years. I've been at the VA for 34 years, and I've been involved with C. diff from actually the late 70s, even before I was at the VA. What I've learned over all of these years, and I'm sure I'm preaching to the choir at this point, C. diff is a horrible infection, and I've, in a little while, going to present 3 cases, 2 of which I were involved with, 1 from the literature, and I'm putting them out there for various reasons. But you know this, a lot of people know this. It's becoming, the same way years ago we talked about MRSA, MRSA infections. We're now talking about C. diff, and it really has even overtaken MRSA as one of the biggest problems in hospital-acquired infections. So, horrible infection, but the laboratory tests that we use to diagnose it have gone from horrible to much better, but we're not there yet. And one of the things I will discuss today is those tests are much better, but a lab test is just a lab test. It doesn't diagnose anything without careful input from what's going on with the patient and having a doctor who tie them together. Because you can be an asymptomatic carrier, you can even have toxin in the organism and not be sick, or as you know, you can have terrible, terrible outcomes. We also have started appreciating, particularly in the hospital environment, asymptomatic carriers who can be the source of infections to other patients, and we're learning how to deal with that. And the bottom line that I'll start with and end with is we can and we must do better. So I want to go to 3 case presentations. And the first case I got involved with at the end, not at the beginning, but it's just an amazing wake-up call to so many things that were wrong here. Now, it's a few years old, but hopefully we'd get a little better. But so 60-year-old male, he had gone to an outside community hospital for what we call, he had respiratory symptoms, and I don't know exactly how specific they got. Did they do x-rays, CAT scans, white count cultures? But probably they did nothing, and they said, you've got pneumonia, so we're going to give you an antibiotic that we just dramatically overuse. It's related to Cipro. I call it vitamin L. Most doctors think patients need a dose of it. So called levofloxacin, a good antibiotic, but just overused. So he got that discharged. He then went to another hospital, but in this case it wasn't C. diff yet. It was that he had gained weight, his abdomen became bloated and big, but he was severely hypertensive. I mean, normal blood pressure might be 120 over 70. He was 216 over 103. He did not have a fever, so he was afebrile. His white count was absolutely normal at 8.5. His albumin, which is a sense in his blood of how much protein is there, was a little low, but probably pretty normal. His creatinine, which is kidney function, was absolutely normal, and he had no diarrhea. So C. diff isn't on anyone's radar screen. So he was admitted to that hospital, that other hospital, treated for his hypertension. but they preferred Cipro, which is not as actually good as a respiratory antibiotic as Levo, switched, but it's nearly the same drug, switched him from Levo to Cipro to complete his treatment for his community-acquired pneumonia, and he was discharged 3 days later. Well, he came to the VA ER 3 days after that discharge, and he had a low-grade fever, and that can or cannot be associated with C. diff. You can have C. diff without a fever, so the low-grade fever there is just, yes, he has a fever, he's had pneumonia, that isn't C. diff, but that wouldn't at all lead me to think of C. diff. He did now have diarrhea. He was not feeling well, but he didn't have any particular abdominal pain. But I put it in yellow. His white count was 27.8. You know, a normal white count goes up to about 10,000. His albumin had come down a little bit, and his creatinine, which is telling me his kidneys aren't doing quite as well, were going up. And with C. diff, as you're getting severe disease or more severe disease, you have organ dysfunction. And one of the things that we've seen is kidney dysfunction. And you measure, there are different ways of doing it, but creatinine is one way, and it's gone from 0.9 to 1.2, which some people would still consider normal, but that 0.3 increase in a short time is a red flag. So they thought about C. diff. It listed him. He was admitted as this was a possible diagnosis, but they, didn't treat it, and they kept him on levofloxacin. There's no mention of respiratory symptoms. So why? I don't know. But by the second day in the hospital, he was having 10 loose stools a day. Now that's a red flag. That's bad. He also had altered mental status. At that point, I was doing a toxin test that looks in the stool directly for toxins A and B. And that test was positive. So they put him on a treatment which was metronidazole, which is one of the two drugs that we used at that time for treating his C. diff. And that TID is 3 times a day. And that was another huge error because he didn't have mild disease. 10 stools a day, a white count of 27,000, you've got to be aggressive with your treatment. That's what we might treat for mild C. diff. And he rapidly deteriorated. He was transferred to the surgical intensive care unit. Anuric means he stopped making urine, so his kidneys, well, and you'll see later, renal failure was shutting down, had shut down. He now had distension, abdominal pain. He developed cardiac complications, respiratory complications. He was ventilated. They asked for a surgical consult, and they just said he's far too sick to bring to surgery. So now they got a little bit more aggressive with the treatment, gave him both oral and rectal vancomycin. They had to stop the oral when he was ventilated and had to then do a rectal form of vancomycin. His white count went up higher, his albumin was going down, his creatinine reflexes, renal failure. Day 4, he had a white count of 60,000 and started developing one of the real downsides of when you end up dying from C. diff. You develop toxic megacolon, pseudomembranous colitis, then toxic megacolon, and the next day his white count was 88,000, one of the highest I've ever seen. You see that in, it's called a leukemoid reaction in cancer patients, but this was really from the C. diff. He was made DNR, and he died. The second case was out of Morbidity and Mortality Weekly Report, and I put it there for a different reason. I will explain the 3 cases at the end. This was a 31-year-old pregnant female who was pregnant with twins early on, but she had had 3 weeks of intermittent diarrhea and then 3 straight days of cramping and watery diarrhea. They did a stool toxin test at that hospital. It was positive. The only antibiotic that she had received was TS's sulfur or Bactrim. She had gotten 3 months earlier for a UTI, but they rightfully admitted her, treated her with metronidazole, and discharged her. But she came back a day later with severe colitis, and she ended up being treated in the hospital for 18 days with metronidazole and oral vancomycin. And they use this toxin binder called cholestyramine, but the problem with using that, it will also bind the antibiotic and reduce the levels of antibiotic. Probably they didn't know that when they did it, and she was discharged. She came back 4 days later, and she had severe diarrhea. She was hypotensive, and sadly, she spontaneously aborted her twins. She had a subtotal colectomy, but she ended up dying, and her postmortem showed toxic megacolon with evidence of this awful stuff when you did this gunk distributed on the lining of your colon, a pseudomembranous colitis. The third case was a case where I was outside of the cafeteria. There was a gentleman legally blind in a wheelchair, and his wife was asking some questions, and someone said, "Oh, there's Dr. Brecher. He's the man you want to see." And it turned out to be a lovely, lovely woman with a 74-year-old husband who was very ill. He had many, many things going on. End-stage renal disease, severe diabetes. He had seizure disorders, vascular dementia, a meningioma, esophageal adenocarcinoma, peripheral vascular disease, and hypertension. And because of all these, and particularly related to the diabetes with the neuropathy or the loss of feeling, he was incontinent, and that all plays a role. So I got involved with him. This was probably around 2013, and I went back and I looked at his chart. And the first time we can document C. diff was in December of 2009. He had a white count of 20,000. He had a positive toxin test, and that, at that point, with his diarrhea, with everything else, pretty good that he had C. diff. Then he seemed to get better, but in February, a few months later, he relapsed, had another high white count. And the high white count is key. In a patient that can make a white count, some patients can't. When they get C. diff, it nearly all goes up, and when it gets bad, it goes up even higher. But then, a month after that, he had some more diarrhea, and we had switched. I don't know if you can see, between 2009 and 2010, we had switched from doing the toxin test to this brand new test that actually it was Cepheid's test that was a PCR. So we weren't looking for the toxin. We were looking at the stool for the gene that is the code word or the code region for that toxin, and it was PCR positive. And I remember that month because I had had my knee replaced in January, and this test finally got FDA approved, and it was the thing I was thinking about every day as I was recuperating at home from my knee surgery, that I want to bring this aboard because I had done a project with a graduate student and realized, how good it was. So we ran that on him and diagnosed his disease in February, but in March, his white count wasn't particularly remarkable, and he was positive, so he got treated. The end of the year, white count wasn't remarkable. He had diarrhea. He got treated. He got treated. Finally, in May of 2012, and I was actually now involved with this at that point, I said, people can have a positive PCR, which is a molecular test. You're not growing anything. You're looking for the gene. So let me look at some of these old tests, and I'll explain those. But he ended up being negative for toxin and negative for this enzyme called GDH. And my feeling was that he was a carrier at that point. And the problem was every time he got a positive test, some doctor, and he saw different doctors at different times, would say, "Oh, we've got to treat him for C. diff again." Finally, when I watched that, I said in May of 2013, I said, this guy doesn't have C. diff. He has a million reasons to have diarrhea. So I'm going to go forward to the next slide and then go back in a minute. But I go forward. What I did is I got an ID physician, one of our attendings, and a GI physician, one of the GI attendings, together in a room. And I said, we really need to review him because he's getting treated for C. diff. He's most likely a carrier based on other things. We can probably try to or need to find other reasons to explain his diarrhea. And we all agreed that he he is probably colonized with low levels of C. diff, in that we don't want, unless he gets a leukocytosis, a increased white count with increased clinically significant diarrhea, we don't want to treat him, because every time you treat him, even with vancomycin or metronidazole, you're still messing up the colonic flora. And you want that to come back. You want the good intestinal organisms there, and any antibiotic's going to interfere with that. So I'm going to go back a slide now. So we stopped doing it. And a year later, when we finally came in again, we were just wanted to see. I asked his wife if I get a sample, and he finally was PCR negative. So he needed that. But I'm now going to go forward and say, why did I present these 3 cases? The first one is there were many mistakes made. The rapid recognition and appropriate treatment of severe disease is essential. And in this case, the patient probably got too many antibiotics, diarrhea and a white count of 27,000, should have reacted, given metronidazole. He should have been given vancomycin earlier. So that man, as far as I'm concerned, should still be alive. And I just think it was a mess. Case 2 was the reminder, because as I've watched this disease evolve, if you were in the hospital or a long-term care facility on antibiotics and had diarrhea, I didn't think of any other causes of diarrhea. See, in the community, we talk about things you read: salmonella, shigella, campylobacter. Have you gone camping? Do you have parasites like giardia? We look for those in outpatients, but we didn't look for C. diff. If you were in the hospital and you'd been here for a few days, you probably didn't get those diseases in the hospital, but you're on antibiotics, you have a pretty good chance of getting C. diff. And this was a case in which a woman in the community, with one remote case of a small, probably 3 days of Bactrim 3 months earlier, who is now pregnant, came in and ended up with very severe C. diff and had a tragic ending for her and her unborn twins. And that was a reminder that, and now I say roughly that 1/3 of C. diff cases are from the community. They haven't been in the hospital. Now, some of them have had antibiotics, but there are other factors, and we don't know them all. In fact, we now think pregnancy, which will change hormones, may change flora, and that may make some pregnant women more susceptible to C. diff. But the wake-up call is community diarrhea, hospital diarrhea. They should get, if you believe they have the other symptoms, a C. diff test. And case 3 I presented because we need to start exploring alternative explanations for diarrhea. We need to look at the concept of colonization versus infection. We have lots of organisms in and on our body. Some of them, if I give them names like Staph aureus, Streptococcus pneumonia, but you can also have them without having disease. So that's a very important concept. And the most important thing I'm going to say to you and to the medical community is the need to know the patient. If you don't spend time with patients, you're not going to get it right. And with C. diff, you can get it right more often than not if you spend enough time, ask the right questions, and do the right tests. So who should be tested? Well, there is a lot of diarrhea, more outside of the United States, but in the United States there are about 180 million cases reported, and that's the ones that get reported. Most diarrhea, as you know, probably doesn't get reported. So if a doctor sees a patient, you have to say, is this likely an infectious cause of diarrhea, or is this a non-infectious cause? Lots of reasons for both, and it's not a lecture here on all causes of diarrhea, but there are numerous inflammatory bowel diseases that can also be associated with C. diff, but have diarrhea unrelated to C. diff. And then we have a lot of viral infections that usually those declare themselves because you get nausea and vomiting with viral gastroenteritis most of the time. So diarrhea, infectious, non-infectious. And then if you were starting to think about C. diff, what is clinically significant diarrhea? And for most people, the definition is 3 or more unformed stools in 24 hours. So one bout of diarrhea, not the reason to do a C. diff test, but 3 diarrhea in 3 episodes of diarrhea in 24 hours, and then maybe some reasons. Again, that's when you start asking questions. Are you on antibiotic? When were you on antibiotics? Have you had C. diff in the past? What else is going on in your life? Sometimes you say, have you been on a laxative? Oh, yeah, I took a laxative. They go, well, then maybe that's the reason for your diarrhea. So we need to find out what's associated, and we don't have a really defined working definition for clinically significant diarrhea. This is a paper that lots of people saw. It was in the New England Journal of Medicine 2 years ago, going back 4 years from when it was published, but trying to get a rough estimate. How many cases do we have? In many states, this is not a reportable disease. So these are estimates. Anything that always ends in 3 zeros has to be an estimate. You can't, the probability, if those are real numbers, play the lottery. But we now know there's well over 500,000 cases, and that 20% or so will have recurrences or failures, and even some of those go on to second and third cases. As you know, there were nearly 30,000 deaths. As I said, 2/3 were healthcare associated. That means in the hospital or in long-term care, rehab, and about 1/3 in the community. In that paper, the risk factors, if you were female, if you were white, and you were greater than 65, there seemed to be even a hard incident. Those were numbers that are hard for me because I'm in a VA and 90-something% of our patients are men, so it's like, oh, I don't see many female patients. And then I consider C. diff a disease of the elderly, and I'm 72, so that 65 looks awfully young. So I want to say greater than 72, but that's not real science. So what are the goals of testing? You want to identify C. diff, and importantly, so a negative test, if it's a good test, is very important. You want to rule out C. diff in patients with diarrhea. Yes, you have C. diff, want to get that right, but just to say, I have a test here that says you don't have C. diff, and I'm nearly 100% sure of that. That's valuable when we're trying to work out what's going on with a patient. If we have patients with C. diff, obviously we want to get them on treatments, and this isn't a lecture about treatments, but there are guidelines of what to use and when to use it. I don't always agree with them, but different ways around it. We also now, and this is starting to become popular, is to do tests in asymptomatic patients. We just completed a study. It was very small. It was presented in San Diego of looking at surgical admissions, asymptomatic carriers on rectal swabs, and identifying patients who are carriers of C. diff. They don't have any symptoms. White count is normal, and those patients are treated like they're put in private rooms on precautions so they don't spread C. diff. We also want to know about those patients and anybody else with C. diff so we can do a better job at infection control and infection prevention and cleaning of rooms and try to stop this chain of transmission, because as you know, the organism forms spores, and alcohol doesn't kill spores. In fact, people ask me, and I said, if I'm trying to grow C. diff, and this is absolutely what we do in the lab, we don't tend to grow it on routine cases, but if I'm trying to grow C. diff, I will take the stool sample and put it in 90% alcohol. And the alcohol will kill the normal regular bacteria, even the regular C. diff. It will kill the E. coli and all those other bugs, but it won't do a thing to spores. So I will now have in that stool, what's surviving is mostly the spores of C. diff and possibly other spores from other organisms. But then I put it on special growth media, and it's a way that stacks the deck in the favor of me being able to easily grow C. diff from that sample. The reason we don't do that routinely is it takes a couple of days to do that, and then another day or two to do a toxin test, and that's too long. I want results in 45 minutes to an hour. So I want to, use these tests to help my infection control program within the hospital, as well as specifically help the patients. And this is what I said a few minutes ago, is that we do tests. If I do a culture looking for pneumonia, I can find organisms normally in your respiratory secretions that cause pneumonia, but what we realize, 10% of people can carry those organisms. So just finding it shouldn't mean you get treated. That's one part. That's the lab test. But if you find it and the patient has an infiltrate on their x-ray or their CAT scan, has a fever, has a white count, has difficulty breathing, you tie that all together. So just finding something, finding that C. diff is there or strep pneumo there. 1/3 of us carry Staph aureus on the tips of our nose. So that doesn't cause disease at the tips of our nose. And what I try to remind people is we have more bacteria in us and on us than we have human cells. And although some people find this disgusting, I find it absolutely fascinating that if you take all of the bacteria in and on your body and weigh them, they weigh about 3 pounds, which is about the same as your brain. And I have thought this for years, but now the world, I believe, is catching up. I consider your normal microbiome, which is the term, all of the normal organisms in you and on you, an organ system. And we need to respect that organ system and only give out antibiotics which will change that system when they're absolutely necessary. And there's all of these efforts now on antibiotic stewardship. The other thing, and to get a little humor in a bad situation, is I came across this quote by Catherine DeAngelis, a pediatrician that I use. I train a lot of interns, residents, fellows, and house staff, and when they want to order all these tests, I give them this quote. Remember, ordering a diagnostic lab test is like picking your nose in public. You must first consider what you will do if you find something. So who to test? People with greater than 3 unformed stool movements within 24 hours with risk factors. I like to look at white count, mention creatinine. In severe disease, that goes up. Albumin goes down. History of antibiotics, inflammatory bowel disease. Are they off of surgery? Are they older than 72? If you maybe completed therapy, it's a couple weeks later and once again have clinically significant diarrhea. Those are the people I want to test. I don't want to test everyone with diarrhea. I like to ask laxatives, tube feeding, diabetes. We used to say do not perform tests on asymptomatic patients, but I'm getting to the point that that may become a standard test, or at least considered in certain populations coming into the hospital. Are you an asymptomatic carrier? What's your risk of developing C. diff? What's your risk of passing these spores on to someone else? As you heard at the very beginning, Christian mentioned, we don't have a test of cure. And the reason is, yeah, we can do a test, but you can be perfectly better and still have a positive test. And that can be a PCR, that can be a GDH, which I haven't talked about yet, that can be a toxin test. So you've got to look at the patient. I don't need a test of cure. I might want to know if you're a carrier. If you've had bad diarrhea, you've been treated, it's now a week later, you're having normal bowel movements, your white count's normal, you feel fine, I can do a test on you and you can be positive. So if we do that, a lot of physicians that say, oh, I got to keep treating them, and then you go back and you get C. diff again. So you get the disease again. So you can even carry toxigenic strains. So that's the reason we don't have a test of cure. I wrote a paper on C. diff in 2013 for Clinical Infectious Disease, and it was called the Brecher Guidelines. For here, changed it to the Brecher stick test. There is a pictures of stool called the Bristol chart mentioned at the bottom of this slide. And it's drawings. It's I misspoke. It's not pictures. It's drawings of stool. Well, I don't want to look at drawings of stool. I don't know about you. But stools 5 to 7 on this Bristol chart are more or less very juicy or liquid, and they say test those. So I came up with the Brecher stick test. So the first part is we look at, and this is what my lab does. You look at the stool, loose or liquid, not loose. So if it ain't loose, it's of no use. So my lab won't do a C. diff test. And then, of course, they came to me and said, well, that's a nice little saying, but what do you mean by loose? So we've learned to take these little lab sticks that we have, fairly thin lab sticks, about maybe 4 inches tall, 5 inches, and we put the stick in the stool. If the stick stands, the test is banned. If the stick falls, test them all. So that's the basis of doing that test rather than looking at drawings of stool. So that's the stool. What about the patient? So how much diarrhea do you have? And I think of mild C. diff, I like to just, people can finesse these numbers. 3, 6, 9 is just easy. 3 movements a day, not real sick, mild. 6 moderate, 9 and going up, getting to severe disease. I mentioned I like to look at white cells. So if you've had a white count of 8,000, you've developed a little more diarrhea, it's now 12,000, 3, 4, 5 movements a day, you get a C. diff test. If you've been in the hospital and your creatinine was 0.9 and it's gone up to 1.3, that's going to catch my attention. Losing protein, making more serum lactate, those are things I like to look at and then try to say, how severe is the diarrhea? How does this fit in? There is a test to do fecal leukocytes, lactoferrin, and there are different versions of it that you can do in stool, and it tells you that there are white cells present. That is of no use in diagnosing C. difficile. It is good for inflammatory bowel diseases, so it has its role, but positive or negative doesn't have any bearing on what I will diagnose or not diagnose as C. diff. So as we get to the laboratory, I'm going to try to keep it simple. We have an enzymatic test. Glutamate dehydrogenase is an enzyme associated with the organism. It doesn't say a thing about disease. It says C. diff, the organism is there. For years, we did these EIA, enzyme immunoassay, for toxins A and B. And I'll talk about those. And now the majority of us, but not everybody, has moved to molecular testing. And I have arrows going up and down and crosswise because some people like to do what I call difficile dancing. Well, we'll do this, it's less expensive, and if this is this, we'll then do this. So if we do a molecular test, do I need a toxin test? So this is an open book. This is not, this is it, this is the way you do it, it's the only way. You can talk to many laboratorians, microbiologists, and they will give you different impressions than what I'm going to say. So the GDH test, this is an enzyme that's found in C. diff. It turns out it's supposed to be in all strains, but when we do this test, we don't find it in all strains. But it's a pretty good test to tell you that the organism is there. But it doesn't tell you a thing about toxin production, and it doesn't tell you much else. So if you do this test, you always have to do a second test. And now, as I say, we're now moving into difficile dancing, because you would probably need a toxin test or a nucleic acid molecular test because of the low specificity. High sensitivity, low specificity. Toxin test, I had a million slides and I just decided to simplify it. So if you have C. diff, you have the organism, you have to have toxins A and B. Either one can cause the disease. Most strains make both, not all strains make both. And if you don't have toxins A and B, if you don't have the genes for toxins A and B, and you get C. diff, you never get the disease. You need to make these toxins. So it makes some sense that we're going to look for the toxins. And started doing this, physicians would say, or nurses would say, my patient has C. diff. I can tell, I can smell it, has a very distinctive odor, it's paracresol, sort of smells a little bit like horse manure. We do the test, and it's negative. And they go, what a lousy lab you have. Do it again. Get another sample, negative. I need a third one. Third one's positive. And when I looked at the literature and the published papers that did comparisons of methods, the toxin test was positive on a range of, or was correct on a range of 30 to 90%. Actually, I should say the sensitivity. There were a lot of false negatives. So let's say on average, 50% of the time it got the test wrong. It said it was negative when it was positive. So what we learned to do with the toxin test was order it times 3. And that slows, so 3 different samples. That slows everything down. One of the problems is these toxins are fairly labile. They break down easily. And because of that, the stool, if it's delayed, getting to the lab, sitting at room temperature, the toxins will degrade. If it's handled properly and refrigerated, the toxins will be okay, but they also will get broken down by these proteolytic enzymes that break down proteins. This is a protein in the stool. So the test had poor sensitivity, a lot of false negatives, and a lot of us said, this just isn't the way to go. A positive test was nearly always truly positive, but it didn't always mean the patient had disease, because I told you earlier, you can have toxin, you can have antibody in your body against the toxin and not be sick. But people with a lot of toxin tended to have more severe disease. We're on our next generation, these aren't yet on the market, of ultrasensitive toxin test called Simoa technology. The limit of detection, it will detect very low amounts of toxins. And I'm not sure where we're going to go with that test, because a very low amount is significant. But again, it's something that as a laboratorian I'm trained to keep my eye on. And then what some people said, well, let's just do the GDH and the toxin test together. And it turns out you can do these one at a time on a lateral flow card. So like a pregnancy test card, if you get sort of that image. And if they were both positive, good result, both negative, good result. But in 2 different studies, 12-13% of the time, there were discrepant results. And then those labs would go to a molecular test to adjudicate what was really going on. And the reason I don't like that is I'm delaying getting the result back to treat the patient. I do this, we'll wait till we do them all, and then at the end of the day we'll do this other test. And I just don't like what I told you, difficile dancing. And this slide looks a little busy, but there's a couple of just quick take-home points. Great researcher, Eric DeBerke, looked at a whole bunch of different tests, 8 different methods, 2 different gold standards. This is the right answer standards. And they looked at patients, submitted stools with and without clinical symptoms, 150 patients. Well, without going through every line in great detail, because of time, they range from those same 150 patients from 35 positives to 50 positives. So which patients really had C. diff? Turned out when they did chart reviews, 20% of the patients were on laxatives and 36% did not have clinically significant disease. Again, the patient tells you a lot, the test can tell you a lot. You have to, tie them together. So molecular testing came out, as I told you, now 7 years ago, 2010. It doesn't look for the toxin. It looks for DNA. It looks for the genes that code for the toxins. They work well. They're significantly more sensitive than enzyme immunoassay toxin assays. Their specificity is lower in patients without clinically significant disease, which means they can pick up patients that are colonized. So negative PCR results, and I mentioned this at the very beginning, are close to 100% accurate. So if you say, well, got diarrhea. I'd really like to know this isn't C. diff again. You get a negative PCR, it's a real good test. And because it looks for spores, spores don't die. I mean, eventually, but they don't die easily. And even if that stool's been left out, you're still going to have spores in it. A positive PCR test, because you can have carriers, you have to correlate the result with the patient. One of the popular moves now in England and in Europe is to say, hey, let's do the PCR as the first test, but let's do a toxin if the PCR is positive. And I'm just not in favor of that at this time. But what is interesting, and again, this is too soon to tell, there was very recently a paper, when you do a PCR test, and I'm not going to get into detail, you can ask me later, and I can tell you, there's a way of saying, when we look for that toxin gene, look for DNA, we get a value called a CT value. And the lower the number, not the higher, the lower the number, the more likely is there's more toxin. And there was a paper that said, and I'm just going to throw out this number, if the CT value is less than 26.35, that patient probably has a lot of toxin. If it's higher, they probably don't. So there's now correlation studies being done, and there was a very good paper published recently, as I said, to look at that, to say, hey, can we do the PCR and, in fact, get some idea of the toxin? So that's a work in progress. There was a paper done in Canada, out of Canada, Quebec area, where they started looking at asymptomatic carriers. And asymptomatic carriers, when they detected them by doing rectal swabs on admission, they reduced the rate of C. diff from 6.9 to 3.0 per 10,000 patient days, and concluded that detecting and isolating C. diff carriers was associated with a significant decrease in hospital-acquired C. diff. So, again, this is a trend that is starting now when we realize the importance of detecting C. diff. So, if you came to me, what would I tell you to do? I'd say, well, I'm pretty happy with a molecular test alone. I've had pressure on me by a couple of my docs to keep a toxin test around, and I haven't given in to that, but I am now starting to look, and I'm doing a little study in my lab now, looking backwards at the CT values and correlating them with patients' chart. I won't tell you not to do a GDH and a toxin A and B and a molecular test, but again, too many steps. I would never just do a toxin test alone or a GDH test alone. There's a reference here of this whole argument in a journal that I'm an editor for, the Journal of Clinical Microbiology, or referee. What is the optimal approach for detection of C. difficile as a counterpoint? So again, I don't know if that's open access, but again, I could look in to see if I could get that to someone if they wanted it. So the other question that comes up, if you've had a PCR that's negative, and I just said, hey, if that's negative, it's negative. Well, a study that was done at Stanford said, should we get another PCR? Docs were so used to ordering 3 tests that in labs we said, you don't need 3 tests. 1 is enough. Excuse me. So from 406 tests from 293 patients that had a negative PCR on repeat, there were only 10 positives, and only 3 of those were positive in less than 7 days. So my rule here is you get 1 test per patient per week. If you ask for a second test, I will do a chart review. I might even visit the patient. I'll at least visit the doctor or get the doctor on the phone. And I will say, white count stayed at 5,000. Albumin stayed here. Proteins here. Is there another reason? And they go, oh, well, they're on a laxative. I said, well, stop the laxative and maybe I'll consider it. But every once in a while, like you see the few positives here, oh, that patient's white count has gone up. Their diarrhea is increased. I will do a second test in a moment. So again, you've got to be involved in the process. If you've had C. diff, and either don't get better or you get better and then recur or relapse, what's going on? Well, most of the time, it's the same strain. You've never got rid of it. Your reasons for your treatments have altered your flora again, and you get the same strain of C. diff back. To my knowledge, there are at least 250 different strains of C. difficile. So there are a lot of choices out there. But in another study, so if it's within 8 weeks, nearly 90% of the time it's the same strain. If it's greater than 8 weeks, 2/3 of the time it's the same strain. So you can have a second strain of C. diff that you pick up. Prevention of C. diff has to be one of our highest priorities now in hospital. Hand hygiene. Remember, soap and water. It's not that soap and water, rather than, these alcohol hand rubs that we have won't kill C. diff. But, I'm not sure soap and water, but soap and water, you're getting mechanical removal. So like your mother said, wash your hands. So good hand hygiene policies, keeping patients in isolation, which is tough on the patients in the ways, number one, they're isolated, and number two, studies show, oh, that patient's in isolation. I'm not going to bother to go in there. I have to gown and glove and do all this other stuff. Better environmental cleaning. We're getting better at not giving antibiotics to everybody who coughs. So that's important. Doctors have to say, do I really need antibiotics? And if you start antibiotics, do they really need, if you get a different diagnosis that's viral, get them off antibiotics. So yes, we can get better at doing all of this. So I've recommended creating a C. diff team. These are the members. I won't read them all. You can see them. But the idea is nobody's an island, and this is a horrible disease. You need to get the right people together, the support from administration, the education of everybody, get the doctors involved, understand the antibiotics, get the laboratory involved, get building maintenance involved, and the importance of what we all do. It's like a football team. One guy isn't going to do it, but you play as a team, things go well. And our mission is communicate and educate, value effective test and treatment strategies, transmission of C. diff, control of that, and antibiotic stewardship. So no laboratory test can diagnose C. difficile infection. You have to correlate the test results with the patient. Diagnostic testing should be limited to at-risk patients with clinically significant diarrhea. I'd love to see starting to screen new admissions for carriage of C. difficile. You need an aggressive infection control, infection prevention strategy, and a difficile management team would be helpful. I believe that's my last slide, so I will turn this back to Christian and the Foundation for questions. I left a few minutes. I'm not in a rush to go anywhere, so I will be happy to answer as many questions as I can. Thank you.
Thank you so much, Dr. Brecher. That was just really helpful, and I feel like I actually learned a lot from it. There was one test that I don't even think that I really was familiar with. So we're definitely happy to take questions. We definitely have a few minutes. If people want to send messages in the chat box, there should be a little message area where you can just sit and type your test in. I can also unmute the phones if people want to ask their questions audibly. So let me unmute the phone. Hi, everyone. So if folks have questions, they can type them in the chat box, or they can just ask them now if you'd like. Okay, we do have a question here from Gerard Honig. He says, given your thoughts on the lack of utility of ELISA after PCR, do you have any thoughts on why and how the UK experience was so successful?
Yeah, these are a very good individual, Mark Wilcox. Most of the work with Tim Plange came out of that lab. And they in that paper, it said, well, here we've got three things. We've got positive C. diffs, they have bad disease. We have negative C. diffs, they don't have any disease. And then we have these people who have a positive PCR, but they don't make toxin, and those are really carriers. I think they used two broad groups. I don't think they included all symptoms, and I think it was a good suggestion that this looked really clean. But when I looked at that paper, the point counterpoint, talked with Eric Fong, talked with some other people, I don't think it was, no, I'm not accusing anybody. I mean, I think they do great work. But our experience, at least here, is that we have patients with toxin positive who have disease. We have patients with toxin positive who don't have disease. I think the best combined statement I can make is, yes, there probably is some correlation between the amount of toxin and the severity of disease, but I'm not comfortable with starting to call everyone in the middle a carrier. Now they looked at mortality, morbidity, and other things. I'm just not comfortable with that, and nor are most of the people I've spoken to here. Other people are. Now, is there a different C. diff experience there? I can't, they might have different strains. Yes, there's epidemiological, geographical differences. But I just am not comfortable with that approach, and I'm not sure when you really break down that data, it's quite as clean as it seems.
Thank you, Dr. Brecher. So Niall's asking, what advice would you give to the family, friends of someone who's in the hospital where C. diff is a possibility or a concern?
So, one, there's a couple of answers to that. So one is, what advice to that person about their disease? So one is talking about the patient. The other part of that question is, what about their risk for C. diff? So, so the first part, you should find out, and that's what I believe Christian and the Peggy Lillis Foundation is doing, is find out, the more you know. When you're in a hospital, you need advocates. You need people on your side. So find out as much as possible about what's going, well, if my husband or wife or loved one has C. diff, what's their white count? How severe do you think it is? Try to know as much so at least you understand what's going on. What are they treating them, and why are we getting just metronidazole? Are there other treatments? What about we didn't get into fecal transplants? Where are they? So the more you know, the better off you are. The other question is then of concern is, are any of us at risk? And the answer is, you are at risk becoming an asymptomatic carrier, and if you're, for any reason, the simplest, on antibiotics, yes, you're at risk for disease. So again, handle gloves, gowns, precautions, and the understanding that in a hospital room, those spores can be anywhere in the room. They're not, they're on the bed. You move around the bed, you create aerosols. They end up on curtains, windowsills, even ceiling tiles. So again, the more you know, the better off you are.
Yeah, I would agree with that. I mean, I think part of what makes this disease so challenging is that there's such little public awareness of it, and so people don't even think to ask these questions or to be concerned about it. We have another question from Sarah, who is actually, I want to give credit to Sarah, I should have started off with this, of being somebody who has really struggled with diagnosis in the past. And she, as one of our advocates in Ohio, and she really pushed us to do some more education around this. So thank you, Sarah. Her question is, she's 8 years into her C. diff battle, and she's a very complicated case of getting diagnosed. She rarely tests positive, but has extreme pain and high white blood cell count. What do you suggest to do to get better diagnosed?
Well, I mean, those are, you look at that and you go, wow. There's not going to be a simple answer. Obviously, after 8 years, Sarah, that there's not a simple answer. One is, when you test positive, what test are they using may or may not be helpful. Is that at the same time you have diarrhea. There is one kind of patient that with solid stool I would test, and that's when they develop ileus, which is paralysis, the segment of the small bowel. So you have to look at that. The extreme pain may not have anything to do with C. diff. It might. So, but if you have a white count of 18,000 all the time, if it correlates that you have an 18,000 white count with diarrhea, with pain, then it sounds like C. diff. But if you have that and you don't have diarrhea, what else is causing that pain? What else is causing that white count? So I'm sure in 8 years you've been to GI specialist, ID specialist, possibly even surgeons. And I wish I could say, oh, I get it. This is what I can do. But now it isn't. So you've had 3 EIA, PCRs, and a GDH. Are those positives? So you've had a lot of, one is if we say that's clinically significant diarrhea, following that high white count, positive test, clinically significant diarrhea, you buy treatment again. Have you tried, and you don't have to answer this because this is a HIPAA type of question, fecal transplant, or has anybody been willing to do that if you haven't had the diarrhea?
One of the questions that Sarah and I had talked about, Dr. Brecher, is that one of the things that she was concerned with is that as she's being asked to drop stool samples off, and you kind of alluded to this earlier, which is like, are these laboratory companies, are they doing a good job of processing the samples, because so that the toxins aren't breaking down or stuff like that? And is there any way to ensure that, or are there better questions to ask of that maybe?
You may say what test you're doing, but she's had some, there aren't a lot of false positives. The trouble, in the testing there aren't false positives. There are people who can have a positive toxin test, and that's not associated with their disease. So this is just very complicated in the sense we have at least of what we understand. And remember, I'm going to make it clear, we don't understand everything. So when we have a nice, clear picture, it ties together the information from the patient, the test. But what I'm seeing here is that this has gone on over 8 years, and there are things that don't fit together. And that means there's not going to be an easy answer. And there are people who are long-term carriers, but it sounds like you haven't had severe diarrhea for all of that time. And so it's only easy, it's never easy, it's easier we can correlate test, clinical information, other clinical lab results. In this case, it doesn't seem that much correlates. So the question is, what else is there something else going on? And C. diff is the red herring, that you are without looking at all that, have you had C. diff positive test? And in this case, if you're just positive over a long period of time, and they're all done by PCRs, then say, yes, you're a C. diff carrier. Does your white count, when your white count goes up, does the CT value on the PCR go down, or do you at that point do a toxin test and try to correlate that with your symptoms if you get diarrhea? But I think you need a doctor that understands this, probably a GI or an ID doctor, who will go over these with you over time. And that may be, I assume they're out there. As I say, I am myself not a physician, so it sounds like, have you had bowels, is there any blockages causing the pain? Is there anything going on with gallbladder? These are questions that I can't answer, but should be thought of other reasons for these symptoms with or without carrying or C. diff.
Yeah. Thank you. I mean, I do think it's complicated, and I think Sarah, you and I should talk and see if we can get you some better answers. Jackie also had a question asking if you've had C. diff and you're asymptomatic, but you're going to have another surgery inpatient stay, should you be isolated?
Now that gets to the asymptomatic carriers. My sense is if you've had C. diff, you can be an asymptomatic carrier. So I might, in that case, knowing to go to the hospital, I would say I would like a surveillance rectal swab to see if I'm carrying C. I'd ask for by a PCR if I'm carrying C. diff. And if you are, in my opinion, you absolutely should be isolated.
Do folks have any other questions? Because we're out of ones in terms of the messaging.
I do have one question, Christian.
Okay.
It goes back to the community infections and possible, I guess, spread of C. diff in the community. What is the percentage, or I guess the amount, I don't know what the term would be, that asymptomatic people could shed, or spread as far as the toxin or bacteria?
Well, they're not going to be spreading the toxin, but everybody has some degree of perianal shedding. But during the day, you're walking around, you don't have diarrhea, you go and you wash your hands. What's somebody who's an asymptomatic carrier, are they spreading C. diff wildly? And in the community, I would say no, but could it be possible they're shedding some C. diff between clothes and hands that exposes other people? And the answer is obviously yes, but most people with a normal, intact, protective microbiome, colonic microbiome, probably get exposed to C. diff and don't become carriers or infected with it, because the bowel flora isn't favorable to the establishment of C. diff as long as the good microbiome is there. So yes, it's possible, but I think it would really not account for very much. What it would account maybe for more is a patient came home, got better, people are taking care of them, they're still in bed. Even without diarrhea, there's some perianal shedding. It gets on the sheets, you flop around. Would it put some more people at risk for being carriers? Yes, but if those people, again, have intact flora, probably low, but it's there. So, once you're a carrier of anything, the risk of spreading it is there. But in this case, I think it's pretty low, but I can't give you an exact number or even quote a paper. It's my own thinking on the matter.
Well, in my case, I have no gallbladder. This all started when I had my gallbladder removed. Mm-hmm. The week after is when I had the CDI infection. So I have real severe bile acid diarrhea at times. Mm-hmm. And I'm just wondering if that could contribute to, I guess, transfer or shedding. And
are you testing positive for C. diff without symptoms?
I have not been tested since my
because of surgical differences and the lack of bile acid digestion, that could affect your flora, and
right.
So that and maybe something that's just not, is it knowing it better or not knowing it? But let's say you're around somebody who's getting chemotherapy and antibiotics, and you go, gee, I went to the hospital and they then got C. diff. Was it me? So at some point, it may be worth knowing if you're carrying at that point. But some people might say, well, we're not going to pay for that test or we're not going to do that test. You're not sick. So you're going to run into the medical system a little bit. But, it may be something you want to know.
Well, my GI doctor, who has been with me since I've had a lot of other issues, from chronic gastritis to ulcers, and now Barrett's with low-grade dysplasia, and now an ineffective LES. So I have a lot of other issues, but he is on board, and with all the endoscopies has not required me to take antibiotics for all the biopsies and things that have been going on. So I think he would probably do the test for me.
The good news that you said, is that you have somebody on board who listens and
yes,
is willing to spend the time and understands what's going on. So that's clearly a plus.
Great. Thank you very much.
You're welcome.
Anyone else? All right. Well, thank you, Dr. Brecher, so much for taking the time and for staying over a little bit to answer questions. We're also super thankful to Cepheid again for supporting this webinar. We will put the recording up on YouTube sooner than later. And meanwhile, please do contact us with questions. Let us know what you thought about this and how we can make webinars better in the future. All right. Thank you, everybody.
Thank you. Thank you, Christian.
Thank you. Bye.
Thank you.
Bye-bye.
Bye-bye.
Yay.